Bismillahirrahmanirrahim. So in today's video we will talk about how the Cpap and the Bipap works to improve the oxygen and wash out the CO2. So till now in the previous lecture we talked about how to improve the oxygen by increasing FiO2. So I will go quickly through those things: how to improve oxygenation, how to improve hypoxemia. A patient comes to you and he is not maintaining the sites. So there are two things. If this is the lung of a normal patient, of a normal person, if this is the lung of a normal person, even in a normal person all the alveoli are not working, or we can say some alveoli are working maximum, other are working minimum, depending upon the intensity of VQ mismatch. So these are called hibernated alveoli. So we are having active alveoli and hibernated alveoli. So how can we improve oxygenation? By making them active. Point number one, if we do something to make the inactive alveoli active, we will be able to improve the oxygenation process. Point number one. Point number two, if we do something that increases the concentration of oxygen in the already active alveoli and the conversion of inactive to the active alveoli and the amount of oxygen in them also. So if we recruit more and more alveoli, it will increase oxygenation. Point number one. Point number two, if we increase the amount of oxygen, the concentration of oxygen in the already alveoli and the newly recruited alveoli, it will improve the hypoxemia. So there are two answers. Fill already recruited alveoli with more oxygen, so that was increase FiO2. So if we are increasing the concentration in each and every alveoli, it means we are increasing the FiO2. Recruit more alveoli. The answer to this is increase in PEEP. Now your patient is not maintaining a SATs, we apply the nasal cannula. Not maintaining SAT, we change that with the surgical mask. Even not maintaining SAT with that, what we do next step is non-rebreather mask. Even if with non-rebreather mask, all these three kinds, they are only increasing the FiO2. The amount of oxygen they are increasing in the already working alveoli, and they cannot recruit more alveoli because they have nothing to do with the PEEP. Or we can say if they are increasing the PEEP, that is less than the desired amount. That is less than the desired amount. Or we can say the amount of oxygen that we give with the high flow nasal cannula, we cannot deliver in our ER and in our setup. Now we have high nasal flow cannulas. So what we do after non-rebreather mask, the next step is apply the Bipap and Cpap. How the Bipap and Cpap helps? It improves oxygenation and it washes out the CO2. So it is helpful in two things. Point number one, it improves oxygen. How? I discussed. It increases the PEEP, and if we attach oxygen to it and give full oxygen, it increases the FiO2. So it can works for both. So it can be used in both hypoxemia and CO2. So how does it improve hypoxemia? We already discussed. Coming toward how does it helps in the CO2 retention, the Cpap and the Bipap. So if this is the alveoli and this is the high CO2 in the alveoli, the CO2 retention over here, what the Cpap and Bipap does, it forces the air to come. If it forces the air to come, what it does, it makes the already present air in the alveoli to escape. If that escape from this alveoli, what happens? There comes the air with less oxygen or with less CO2. If there is air with less CO2, what happens? in the blood there is high CO2, there is diffusion. If there is diffusion of CO2 from the blood in the vessel to the alveoli, and that air is escaping with time, what happens? There is washing out of CO2. Point number 1. Point number 2, it helps the inspiratory muscle. It takes the effort of the patient, what he was making effort to increase the oxygen and to decrease and to wash out the CO2. So the inspiratory muscle were also fatigued. So it takes all those efforts. So it helps inspiratory muscle. The person has to apply the least amount of force, the least amount of work by inspiratory muscles, and his work is done by the Cpap and Bipap machine. So second answer is that makes the breathing process very effective, and that exhale the CO2 quickly. Third, it is helping the diaphragm, because the diaphragm is already fatigued and the muscle fiber, they are not working, so it is taking the effort of diaphragm. So till now we discussed the Cpap and the Bipap. Both increase oxygenation, how I discussed. Both wash out the CO2, how I discussed. Now we will discuss how the Cpap and the Bipap differs. Point number 1. Point number 2, how they differs. That is point number 1. What are the indications of the use in the ER and the ward? Point number 3, what are the contraindications? So what is the difference between the Cpap and the Bipap? The Cpap delivers a single pressure. Whether during inspiration or expiration, we are having a single pressure. The Bipap, as the name shows, by 2. During inspiration, we have one kind of pressure. During expiration, we have another kind of pressure. So this is a more advanced type, but still the Cpap are used. Why? Because of economical reason. That is cheap. Cpap is easily available. That is cheap. Bipap is expensive. So that is the main difference between the two, and the best is the Bipap as compared to the Cpap. Now what are the indications? When will we apply them? Number 1, decrease oxygen, hypoxemia. The patient is not maintaining the SATs, and you have tried what? Nasal cannula. You have tried what? Non-rebreather mask, surgical mask, non-rebreather mask. If the patient is not maintaining with oxygen with that, next step is apply the Cpap or the Bipap. Well, it is said hypoxemia due to cardiogenic pulmonary edema, it is best, especially the Cpap. Community acquired pneumonia, ARDS, you should try this. And the second is, so this condition is called, if the oxygen is low, type 1 respiratory failure. The second, you can use it in increase in CO2 in the blood, and that condition is called type 2 respiratory failure. It can be used in the COPD. It can be used due to any condition which cause this setting. When can we use the Cpap and the Bipap? These are the indications. The pH is 7.25 to 7.35. If the pH is less than 7.25, the answer is ventilator. The answer is ventilator, not Cpap and the Bipap. If the PCO2 is more than 45 and the bicarb is equal to or more than normal limit. What does it mean? It means you are excluding metabolic acidosis. So it is only used in the respiratory acidosis. You cannot use it if the person is drowsy, if the person is unconscious. In both these two conditions, ventilator is the answer, because the person cannot wash out the CO2. So that was the main thing. So now coming toward the settings of the Cpap and the Bipap, the settings. Now before coming toward the setting, if the person is not maintaining this, if the person is maintaining the oxygen saturation and the problem is only CO2 retention, you are not needed to attach the oxygen with the machine, but only apply the machine. No need to attach oxygen with the machine. Only apply the machine, but you have to look for the fitting that there is no leakage. If there is leakage, then it will not work. Second is, if the person is not maintaining oxygen sats, now this is the time to attach the oxygen with the Cpap or Bipap machine. So the setting for the Cpap, the range is 4 to 20 centimeter of water, but we take the average of 10. So we start the patient on 10 centimeter of water, and we can increase it if we are not achieving the response. For the Bipap, of course, we are having the IPAP and the EPAP. So we set the inspiratory pressure of 10 and the expiratory pressure of 5 in the machine, and then we increase it according to the response. So the difference between the two, the 10 and the 5, that is called tidal volume. The difference between the two is the tidal volume. So if you are increasing the IPAP but keeping the EPAP constant, you are increasing the gradient, you are increasing the tidal volume. Or if you are increasing the EPAP and not increasing the IPAP, so you are again decreasing the tidal volume. So you have to keep this difference constant in order for the tidal volume to be delivered. So you should think of this gradient. If you need a high tidal volume, increase the difference between the two. If you need a low tidal volume, decrease the difference between the two. Now there's a term called dependency. If you apply the Bipap machine or the Cpap machine to the COPD patient, the patient becomes dependent on it. By dependent, I mean if you remove the Bipap, he will again retain CO2 and there will be hypoxemia. So what we do, we apply the Cpap or Bipap intermittently. That is 4 hours on, 4 hours off, until the CO2 is washed out. If a patient comes to you with acute exacerbation of COPD and he's retaining the CO2 in the acute setting, what will help you to reduce mortality? Is it oxygen, or is it steroids, or is it the Bipap or the Cpap? The answer is Bipap or the Cpap. Oxygen in the acute setting is not reducing the mortality. It is the Cpap and the Bipap, the CO2 wash out. So this was the setting of the Cpap and the Bipap.